Our first speaker this afternoon is Kenneth Goldschneider, who is on EB Center team at Cincinnati Children's Hospital Medical Center. He's going to be talking about approaching pain in EB. For you.
Thank you, Jerry. Thank you, everybody. It's good to see some familiar faces. I haven't seen some of you guys in a while, and welcome to all the folks I haven't met. I suspect that I'm not going to cover huge amounts of things that you guys don't know a lot about. The EB community is one of the most knowledgeable about pain as any community I've ever met. But maybe there'll be a few things here and there. What I really want to do is go through this quickly enough so that we have time for questions. Yes, ma'am. Thank you. No, it's probably not. Is this better for everybody now? Thank you. All right. Well, darn. Now you actually have to hear what I say. Blame her. So I'm going to try and cover and then leave enough time for plenty of questions, because I find that often once we get the process of questions going, we can really address some of the things that are most pressing. Everything else ends up being kind of generic. But one of my main objectives is, in presenting what I'm going to show you, is even if I've gone through it quickly, it's to be able to go back to your local physicians and say, I feel like I have more ground to stand on when I make a request for one medication or to try something. Because I know that it comes up frequently that local physicians who don't have a lot of experience either with pain medications or with EB are very fearful when you combine the two things and they're asked for stuff. They've got regulators, rules, laws, and all that breathing down their neck on the pain medications. And then, of course, when you add that pressure to, well, EB is complicated and I only know a little bit about it because, well, you're teaching me about it because you're bringing your child in for the first time or you're coming in for the first time, means that they're often hesitant even if they have a good heart and want to help. The other thing I'm going to offer is I brought a big stack of business cards, and anybody who wants one to bring back to their local physician to say, if you want some guidance, just want to run stuff past on different ideas and feel more comfortable in prescribing, please give it to them and they can call me or use my email, okay? So typical, because I'm talking about medications and stuff, I don't get money from anybody for anything. And as far as the FDA is concerned, half of what I'm talking about isn't FDA approved because the FDA approves very little for kids, relatively speaking. So anyway, pain is a complicated kind of thing. And one of the main ways to go about taking care of chronic and ongoing pain or even acute pain is to hit it in as many ways as possible. Because pain's an experience, it's not just a sensation. You can get a paper cut or you can drop something on your toe or whatnot, and it's going to hurt, but there's not a whole lot of suffering involved. But if you have something that either drags on or is complicated by other issues, worries, stresses, medical conditions, and so on, it becomes very different than just sensory input. Okay? So I put this up as an example of what it comes out of one of our books, Treatment of Back Pain. Well, that's not directly relevant to EB, except to know that even for something that's simpler than EB, that we hit it hard and we hit the pain with a whole bunch of different therapies. And we get better results that way as far as helping people function and keep more comfortable. So as far as what I call regular procedures, things that come up frequently, regularly, but they're not, say, full-blown operations. There are a number of different options depending on the age and the situation. We're going to go through some of those. Now, for babies, where we're often uncomfortable, all of us, a little scared of giving a lot of high-potency medications to the little ones, pacifiers are available, where if you give a couple drops of the sugar solution or put it on a pacifier, and especially if you let them suck on the pacifier at the same time, provide some pain relief for the little ones. Now, as you get into the older infancy, it doesn't work quite so well, but it can be effective. It's been studied in things like circumcisions and blood draws and things like that. So that's certainly a non-medication way that's been shown to take care of pain. Anxiety, of course, as we all experience, when something's going to happen that is painful, we tend to get a little nervous about it. And that obviously, as many of you know, gets compounded when it's something bigger than a little thing and when it happens all the time. So there's often a role for the what we call the benzodiazepine group. That includes Valium and midazolam and that kind of thing. Some of it the midazolam can be given intranasally. That can work nicely. It's actually become more and more prescribed for seizures these days because it's a fast and effective way of giving it. We use it sometimes before operations when kids come to our operating rooms because, again, it works quickly. It does tend to burn, so I can't promise that the child would want to take it more than once or twice before saying, I don't like the way it burns. Anxiety can build up over time, and so some of the newer antidepressants are helpful in kind of keeping that edge off the anxiety to keep it becoming an everyday overwhelming thing. Now, as far as the traditional strong pain medications, the opioids, which are the morphine and related class, you can tell from on the left, there's a ton of them. You can tell from on the right, there are a ton of ways of giving them. Now, the ones in red I put up there because they're in that class, but you'll probably only see them used in the hospital. They're very specialized medications. But as I was having a conversation over here on the left, you can respond well to one and not to another. So if you're taking something and it's either giving you a side effect or it just doesn't seem to work right for you, you've got a number of choices, and it's a little hit or miss, since right now there's no predictive way of saying who's going to do well with one versus another. So it's a little trial and error, and you and whoever's prescribing the medication just need to be a little patient with that and just find the best one. And that brings up 2 points. One is these medications are scary to a lot of folks. These are, from my standpoint, tools to do a job. If you have a job, use the right tool. When the job is done, you put it away. All right? And I say that and it makes it sound really simple, but it shouldn't get that much more complicated. If you try to make it more complicated, it then becomes more complicated. Obviously, you can do all sorts of nasty things and use these badly and for the wrong reasons and stuff like that, but by and large, if you have a pain problem, you've got something that works for it. That's what it's there for. The other question that comes up is, how much should I use? How much is enough? And I have a definition that I came up with a long time ago, and the definition of enough pain medication is the amount that makes the pain minimal without having more than minimal side effects. That is to say, it's not a particular number. It's not this many milligrams or this many milligrams per body weight. It's how much works before it gets to be more of a problem than a help, and that's all. Now, what are the things to watch for? Watch for the acetaminophen. There are a lot of combination products out there. Hydrocodone does not come plain. Codeine does not come plain anymore. So if you're going to use those and then be taking a Tylenol or Pamprin or any of the brands, or you can take a cold product with acetaminophen, you'll see a lot of the press, and it's relatively recently, there are a number of people who have become toxic with acetaminophen, not the narcotic. The narcotic will make you sleepy, you can overdose and all those kind of things if you take a ton of it. But generally speaking, the long-term effects of a whopping dose of Tylenol, or acetaminophen, not to blame Tylenol, can be significant.